briefly review swallowing, and then go on to some fun stuff, I guess. And this one basically doesn't show
It
up.
doesn't work on
Oh, then I'm kind of stuck with that. There's no way for me to, well, I'll do it this way. Is that okay?
Yeah.
All right. Otherwise, I can't do it. Anyway, with swallowing, you have to, if you remember your GI tract, you, as an adult, you have control of what goes in and what comes out. As a newborn, maybe not so much, okay? But as an adult, you have control of what comes in. Obviously, what you put in your mouth, you know. If it doesn't feel right, tastes bad, you're gonna spit it out. If it tastes good, everything is pleasant, you're gonna swallow it. You're controlling that part. That's the voluntary state. And just like the bolus of food, your tongue pushes it up against the hard palate and starts moving it back towards the pharynx. Okay, there you're going to start activating sensory receptors, and they go through the central nervous system to the swallowing center. That's good. Now you don't have to memorize anything. Swallowing center, and now begins the involuntary phase, if you will. And basically the pharynx is going to contract, and that's showing you there. The green one is the bolus of food, and then propel the food down into the esophagus, and the esophageal phase will begin once the upper esophageal sphincter opens and has lowering in pressure. Okay, that's low. There's notes at the bottom of this to read it. So that pharyngeal phase is the phase that's up there, but it's all involuntary. Once that material reaches the back, you have no choice. You swallow it, and that's it. Okay. Here's the problems you encounter, and in blue I've circled the final common path. You can breathe through your nose or through your mouth. It's not a problem. It all goes through this oropharynx region, and if you're swallowing, it's the same pathway. Okay. So something's got to give. So when you swallow, you have to close off your trachea to prevent, that's the serious part, pulmonary aspiration, okay? Now, nasal regurgitation, some of us may have experienced that already, and that's the failure of the soft palate going up, and comes out your nose. So some people have been drinking some fluid, whatever it is, Coke, whatever, and they start laughing. Sometimes that fluid will come out of their nose, okay? It's harmless, pretty much. You don't want it to happen. It's not pleasant, but it can happen, okay? So more serious issue is if it goes down into the trachea, pulmonary aspiration. And these are protective mechanisms in place. You also, when you swallow, the swallowing center, it has spill over into the respiratory center, so you stop respiration as well when you swallow. So that's a good thing. But also, the soft palate goes up, closes off the nasal pharynx, okay? And also, the epiglottis goes down, closes off the trach. All right, so now you can use that common pathway for swallowing. All right, those are protections. And then once it enters the esophagus, you're clearing it and moving it down into the stomach. These are some of the techniques now that are available. You can do this if you're in private practice in your office. Fiber optic, small, look how small these endoscopes are. And they're very flexible. You put it right down to the nose. And in this case, they're using green dye or something. You put it into semi-solid food or liquid, and you can evaluate a person's swallowing. And this shows you, but it's defined here. The opening one is where the esophagus is. The person swallows. You can see the green dye from the fluid. And if that green dye shows up in this region, guess what? The person's going to cough or something else. Okay? There's a problem with his swallowing. Okay? The oral phase is swallowing. That's the common technique now used to determine oropharyngeal phase of swallowing. We'll come back to that. Okay, you swallow, and now the esophagus is going to clear, and that's esophageal phase begins with upper esophageal sphincter opening. Basically, it's, yeah, I guess you can call it opening, it's decrease in contraction of the muscles in that area. And the major ones involved is the IPC, I hate saying it, inferior pharyngeal constrictor, and am I pronouncing it right? Cricopharyngeal, CPIP. And this is myoelectric activity in the muscles. They're in a tonic state, they're contractile, okay? They're tonically contractile. And with the swallow, there's two things. One is the pressures in this area. If you measure the pressure in this area, it's around 80 millimeters of mercury. Some people say it's 100, whatever, but it's pretty high pressure. And when you swallow, the pressure goes down. That's what they call opening of the upper esophageal sphincter. And this is due to a withdrawal of vagal tone. In other words, there's vagal tone coming down somatic on these muscles to make them partially constricted, okay? And then when you remove that tone, the electrical activity in the muscle dissipates, and then there's rebound once you're down, and this rebound here is an increase in pressure, and that's to prevent reflux. A similar rebound in pressure, relaxation and rebound occurs in the other sphincter and other sphincteric muscle types. Is that okay? So in the upper esophageal sphincter, the way it opens when you swallow is through removal of vagal tone. All right, it's going to be different than the lower esophageal sphincter. Okay. All right, now the contractile wave is going to have to move through. This is upper esophageal sphincter, lower. You can see it, right? You can read it back there. Yeah. Okay, so you're swallowing now, and the contractile wave moves smoothly down the esophagus, moving the bolus down into the stomach. This occurs even though the upper third is a different kind of muscle than the lower third. The upper third is striated muscle, the lower third is smooth muscle, okay? And they're regulated differently, okay? And then once the lower esophageal sphincter opens, the bolus will pass into the stomach. Okay, the controlling from the swallowing center, in the upper esophagus, going to the striated muscle here, comes from the nucleus ambiguous. Did I say that? Okay, I don't know how to pronounce it, but anyway, it's somatic motor neurons through the vagus. Okay, it's a typical end plate potential, if you will, releases acetylcholine. This is a nicotinic cholinergic receptor, and there's a nerve fiber on each muscle fiber. Okay, that's the way it works, all right, in the striated muscle. Now, they're bringing up the smooth muscle here, which is in the lower esophagus. That comes from the dorsal motor nucleus. And in the myenteric plexus, you're going to have excitatory and inhibitory neurons, okay? The excitatory neurons will release acetylcholine. There's notes on this. And substance P, those are going to be contractile or excitatory neurotransmitters. Inhibitory neurons release vasoactive intestinal peptide, VIP, or the gas nitric oxide. And nitric oxide doesn't have a receptor really because it's a gas, but it activates guanylyl cyclase. Okay, so that upper part of the esophagus, striated, motor, somatic neurons, vagus, okay. And we know that in the upper esophageal sphincter area, removal of vagus tone is going to relax that area, okay? All right. And in lower esophagus, we're dealing with the myenteric plexus. Remember that? Myenteric plexus is between the circular and longitudinal muscle layers throughout the whole GI tract. And it's a pre-programmed system for peristalsis. Here's the way it works. This is one from the nucleus of vagus. That's somatic to an individual muscle, if you will. And in upper part, or striated muscle, it comes down because the central nervous system activates the nerves going to the upper, mid, lower portion of the striated muscle sequentially. So the central nervous system is regulating the contraction coming down here, okay? But once it hits the smooth muscle, it's programmed by the myenteric plexus, okay? Which, if you remember peristalsis, it's an area of relaxation preceding an area of contraction. Remember that? Okay, I think in the next slide, show again. So they're regulated differently, but as you can see, the contractile wave moving smoothly down this esophagus. And this is programmed, the circuitry of the myenteric plexus, acetylcholine, substance P, neurotransmitters, contraction upstream of the bolus, and downstream at the same time you'll have relaxation so that this bolus moves down. And it's programmed that way. It always goes aborally, okay, or caudate, if you will, toward the anus all the time. You can have what they call retroperistalsis and propulsion, but that's not pathological. Vomiting might deal with that. Is that okay? That's pretty straightforward. All right, now this is manometry. Basically, you can call this a nasal gastric tube, just like that fiber optic where they stop it right here and they take a picture of swallowing. Here you can pass the tube all the way down, and this particular tube will have pressure sensors at different locations, and you can see whenever a contractile wave comes here, the pressure will go up and down, and now this manometric, it's called high resolution manometry. It's computer assisted, and the strength of the contractions are color coded. So if it's bright red or yellow, it's a strong contraction. Green is relaxed. Anyway, so it's a lot easier to do now, and it's all computer generated. And what I'm attracting your attention here is you swallow, you have a pharyngeal contraction during swallowing here. And here you'll see in red, these are high pressure zones, okay? And this one pretty close to 100 in the upper esophageal sphincter, okay? Lower esophageal sphincter maybe around 30. And they're contracted, if you will, in rest. And in blue, it's the esophagus mostly in the thorax, right? It's going to be negative pressure, 0 or negative. Remember that? So how you breathe is by creating a negative pressure, right? And some respirologists a long time ago used to use the esophagus to measure breathing because the esophagus is a passive tube, right? It reflects whatever's going on in the thorax, okay? Pretty much collapsed, if you will. And now bringing it up, UES, relaxation is due to vagal tone removal. We talked about that, right? Whereas the lower esophageal sphincter, you're going to have the release of inhibitory transmitters, which are VIP and nitric oxide, through the myenteric plexus, okay? The direct effect of the vagus here, the vagus is working through the myenteric plexus on smooth muscle, okay?
Yeah.
Yeah.
Does the Meissner plexus also take neurons from gets stimulated from the central nervous system?
Pardon me?
The Meissner plexus.
Myenteric plexus? What about it?
The Auerbach.
Auerbach? I think it's the same thing. It's a different name. I just call it myenteric. The other one is submucosal, or Meissner's. Submucosal deals with blood flow, water movement. I think you're right, Auerbach's, I don't know. We call it myenteric though. Okay, good. This is barium swallow, getting a few techniques, but you've seen all this before, right? Not new. And basically just you're measuring a contractile wave coming down here again, manometry if you will. And barium is just like the green dye, except it's now you can see this on x-ray. And you can see that as the contractile wave is moving, it's pushing the bolus down into the stomach, okay? So it's a technique to measure esophageal peristalsis, dysphagia, if you will. Secondary peristalsis, that has nothing to do with the swallowing, okay? It doesn't involve pharyngeal responses in any way, or contraction. Remember, there's just the swallowing, if you will. There's primary peristalsis, referred to when you swallow. Secondary is independent of the pharyngeal swallowing, and the receptors or the triggers are coming from the esophagus itself, okay? Either during the swallow, not everything was removed. You won't know this, but let's say your primary peristalsis didn't move everything down, be it liquid or solid, a secondary wave through this reflex, the receptors on the esophagus, will come down and clear the esophagus, okay? It's called secondary peristalsis. It's uncoupled from swallowing, it has nothing to do with, or if you reflux occasionally, it doesn't mean that you're gonna sense it, depends on if it's acidic or peptic or something, whether you actually feel the reflux. But if you reflux from the stomach, it triggers these receptors, has nothing to do with you swallowing, but again, it clears the esophagus, okay? The esophagus is always gonna remain empty because this collapse is empty because of the pressures in the upper esophageal sphincter and pressures in the lower esophageal sphincter. They're closed, so it stays empty. Okay, pretty straightforward. Now we're getting to the fun part, dysphagia. Dysphagia, well, may not be interested in it now, maybe when you get older, but it's a fairly common problem as people age, and has nothing to do with aging itself as much as problems associated with aging or disease entities that are incurred as you age, okay? Stroke is a classic. Do I have it here? No, I'll show you later, but you know, as you get older, things go wrong at that stroke, you're gonna have dysphagia, drooling, etc. And stroke, yeah, I wrote stroke, GERD, over time. And we're gonna be dealing with aspiration. That's gonna be the major problem. I showed you that one common vinyl pathway. As long as, once you develop dysphagia or problem associated with swallowing, you've got that complication of aspiration, pulmonary aspiration, okay? And what's that gonna do? If it's food particles, then you're talking about a nice little broth nutrition for bacteria, okay? And if you're talking about acidic or toxic content, then you're talking about damage to the lung parenchyma itself. Anyway, aspiration is a major problem. Malnutrition, you can try liquid diets, etc. We'll get to that. Clinically, it's oropharyngeal or esophageal phases. That's the way you separate it. Obstructive, neuromuscular. Obviously, obstructive would be developing cancer or something in that area. That's obstructive stricture. Esophageal, we'll get to that. Now, swallowing disorders, you can have the oropharyngeal phase, let's say this area, this is the esophageal phase. Surprisingly, this has nothing to do with gastroenterologists. If your patient has a problem with the oropharyngeal phase, they call in a speech therapist, or what they call a speech and language pathologist, okay, SLP. And basically, because most of the musculature there is voluntary and controlled, the speech therapists, they're even used by people like politicians who make speak clearly, enunciate. I mumble, but other people speak clear. But you know, they have methods or techniques to help them, patients develop the musculature to help them swallow, because they can control it yet, okay? It's still voluntary musculature, all right? And that's why you call in a speech pathologist. If it's esophageal, then you deal with it within a GI consultant. Some of the common questions I mentioned, stroke, show you a little bit of that, or anything to do with muscle and neural problems, okay, and develop with old age. And then the Zenker's diverticulum, that's a cute one. We'll get to that now. Killian's triangle. Killian is obviously some physician or something who first described this area. It's right there between the two major muscles of the upper esophageal sphincter. It's weak musculature in that area. And, see, I got this in red, and this here, these are pretty high pressures that can be generated. And if you have spasms or something like that, your pressure can even be higher. At any rate, you can push this muscle out, and it creates a diverticulum, right? Or a Zenker diverticulum. It's not very common, okay, but it can occur. And what's the patient will present with halitosis? He says it doesn't feel like everything's going down. He or she does not know that they have this diverticulum. And guess what? This thing is a nice little breeding ground for bacteria. That's where the halitosis comes from. and then sometimes the food gets regurgitated. That's kind of what it looks like. I think you can tell that, you'll see it come there. That'll be a barium swallow, not, you know how barium works. And this is your esophagus. This would be an endoscopic view. And this is this little bridge here. Oh, did I do that?
That's a touch screen.
Yeah. The esophagus, and over here is a blind end pouch. That's the articulum, okay. And the way they treat that, they go into the neck. It's kind of a small incision. They just cut it off and tie it back up, okay. And get rid of it. But now they have endoscopic approaches where they try to break this bridge, so they make one channel instead of two. It sort of destroy this area here. It becomes a bigger pathway, but it becomes a single pathway. Okay, they do that endoscopy. Okay, let's look at some of these esophageal problems. Achalasia, this is your classic little picture of achalasia. You've all seen this before, right? Yeah, that's the end stage. It usually starts out with, well, they don't know what causes it. Some people, I guess the most common thing that's brought up is probably an autoimmune disorder, develops over time. It's not congenital, in other words, doesn't happen to adult onset, if you will, and some kind of autoimmune reaction which starts destroying, first selectively, the inhibitory neurons, nitric oxide, VIP releasing neurons, and so it creates a higher, doesn't allow this to relax. It doesn't create higher pressure. All right, it's a higher, you're losing your inhibitory, so your contractile events are dominant, and the pressure is higher in the LEF, and proximal dilation develops because now even the cholinergic neurons and substance P excitatory neurons also become affected. And this, what this develops here is this constriction here, and eventually this dilate. The person is not really just starving to death. Malnutrition may be a problem, but all this works only when the person's still alive and comes to see, because as soon as this column of fluid or material gets high enough, hydrostatic pressure, to overcome the pressure down here, some of it dribbles down into the stomach, and they keep doing that. So it's permanent dilation. And they call this a bird beak appearance, if you will. That's classic, but this is end stage achalasia, okay? And we'll deal with how to deal with that in a minute. And scleroderma, that's a systemic disease. You must have had that somewhere, right? It affects a lot of organ systems, and one GI, and it's a connective tissue problem, and you get fibrosis, scarring, atrophy of muscle, mostly smooth muscle in that area, and the LES pressure is lower, and contractile activity is diminished as well. And you'll also have a diminished peristaltic activity in achalasia. There's one more, I think. Yeah, diffuse esophageal spasm, and these are high pressure contractions in the esophagus, and they can occur all at the same time. There's not a coordinated activity anymore. The B thing is showing you a contractile wave moving down, and here these waves are very strong, and they're all occurring at the same time. This is a cartoon and a barium image of that. A real high amplitude, uncoordinated contraction, and it can be quite painful because of the high, strong contractile activity. I think it's retrosternal and can radiate to arms and neck region, and basically in an elderly person it mimics angina. So you don't know whether the person having a heart problem or it's just this, which can be treated medical with pharmaceuticals. Okay, you can calcium antagonists, stuff like that. But at any rate, that's the danger to that one. You can lead to misdiagnosis, if you will. This is a summary how to use manometry to diagnose. the cute things for exam questions and stuff, right? Wouldn't you use this for an exam? Hey, I got this good idea. No, okay, you have a decrease, and they're showing you esophageal contraction. This will be swallowing, laryngeal, upper esophageal sphincter, lower, and what goes on in the esophagus, right? All color coded for you, right? Scleroderma, destruction of this tissue, connective tissue disease. Nothing wrong with your swallowing or anything, but not much in terms of peristaltic activity, and lower esophageal achalasia, lower esophageal pressure, right? Peristalsis, nothing wrong with here. This is obviously spastic. So it's diffuse esophageal spasm, and I put stroke over there, and basically it might be more than likely it is, but it's all upper pharyngeal, has nothing to do with the lower, all right? So they can use manometry to pretty much figure out the cause of the dysphagia. Okay, a little bit about LES. It's all coming through circle here. Remember from cardiovascular or anything really, fluid or anything is going to move down a pressure gradient, right? Now, this is a nasogastric tube, if you will, goes down through the nose into the stomach, okay, past the LES, and it's got a pressure port sensor at the end, and they're just pulling it out of the stomach into the esophagus, okay? So what they see here is your gastric pressure, intragastric pressure, 5 millimeters, which sounds good to me. And here it goes below negative. You're in the thorax, right? You expect it to be negative or close to 0, right? But here you got this high pressure zone. So the gradient, the pressure gradient for moving the fluid is actually from stomach to the esophagus. And the only thing stopping stomach contents from going into the esophagus is this zone of high pressure, right? Lower esophageal sphincter. It's a functional sphincter, it's not anatomical, if you will. And I'm dealing with it here. They called it here internal, external. I don't know if you had this or not, but this is there's an esophageal component and a diaphragm component to the LES, okay? The esophageal is the musculature of the esophagus in that area, and 50% of that pressure is going to be generated by the esophageal muscle. 50%, the other 50% of the pressure is going to be generated by this, that's what you say, crural? That part of the diaphragm? How can anybody pronounce this? You guys have to pronounce it. Crural diaphragm. So 50-50, diaphragm and esophageal muscle. Okay, they're called lower esophageal sphincter, but obviously one's a diaphragm and one's esophageal. So how are you going to get reflux or flux from the stomach? It doesn't take a rocket scientist to figure this one out, right? Either raise intergastric pressure above this or lower this. Okay, those are the only two ways you're going to get it, or you do both, I guess. But it's the only way you're going to get movement of fluid from the stomach to the esophagus. Okay, so, or if you tip upside down, gravity will help. All right, and this is hiatal hernia. Very cute little thing. Did I say it wrong? No. Is that the way you pronounce it? Hiatal. Anyway, what it is it's not common, but it can occur with obesity, and sometimes weightlifters, if you're straining, any increase in intra-abdominal pressure, that's one of the mechanisms proposed for how the stomach gets pushed up into the diaphragm. And there's other forms of hiatal hernia, okay? But basically, I'm not going to get into the flat valve thing, I don't even understand it, but here you have the diaphragm component, right? And this is your esophageal component. Now what you've done, the esophageal component is here, diaphragm is here, right? So yeah, you've increased the pressure, dropped by 50%, but the length of this area is increased compared to this, okay? So as a cartoon, basically you're going from this pressure to over a longer distance, but a much reduced pressure. The problem is you lower your lower esophageal sphincter pressure that way, right? Does this make sense to you? Okay, that's it. Okay, and so there's a tendency for reflux, okay? All right, we have gastroesophageal reflux. That's the disease, GERD. That's when you have enough reflux of material that causes damage. Now you can literally call it a disease, okay, because it's not right? But most of us have reflux. Transient or LES is specifically referring to non-swallowing, okay? TLES are transient lower esophageal sphincter relaxation. You're not swallowing, but you can have relaxation. People do that, not depending on how common it is. And some material will come up into the esophagus and the stomach. Lower LES pressure, you know that, right? Some people have it because their musculature isn't as strong or becomes weaker with age or whatever, and their pressures may drop to around 10 millimeters of mercury as opposed to 30 or something. Intra-abdominal straining, as I mentioned, weightlifters or something like that. You're always straining them. Okay. But you have a defense against that. Right when you have material come up, you know it's going to happen, right? You're going to have secondary peristalsis. Right? You're going to clear your esophagus. Once material comes up in here, your esophagus secondary waves, they clear. That's their job. Okay, that's what they do. Once you detect material. You don't detect it, but your nervous system is. And also you have salivary. Now, if you ever had pretty strong heartburn or reflux or acidic material, you have water brash. That's the term they use for it. It's very copious salivary secretion. And I don't know if you've ever had strong heartburn, you'll notice that you're salivating like a tremendous amount of fluid going down it. And it's all bicarbonate rich. The salivary gland puts out alkaline fluid, right? So these are your normal protective mechanisms. And when they go wrong, or this is exceeds that, obviously, now you're dealing with injury and GERD. All right, now I wasn't going to let you know what iatrogenic is, right? That means you caused it. I have to bring it up. Well, you're going to do that. Decision making, right? That's what your job is as a physician. This is for achalasia, and it's called POEM, or it's myotomy. They cut the esophageal muscle, and they now can do it. I don't know if it's recommended here, but in the U.S. now they do it for achalasia, all forms of achalasia, and for they've been using it for spasms as well, diffuse esophageal spasms, and they can come in. This is with an endoscope, flexible endoscope. They come in, they got scalpel and clips. They come in, they tunnel under the submucosa there, get in there, cut, and then they clip it closed, all with an endoscope. Very little post-operative care, right? But what's the problem here? They just took care of your LES, didn't they? Granted, achalasia and spasms are going to cause nutritional problems. Okay, no one. You can imagine you have to eat so much to get this material down. It's a nutritional problem. The patient's going to wither away. So you make a choice. Oh, we're going to cut. Okay. So now you predispose this individual to reflux, right? And potential for developing GERD. But you made that choice. You know why it's okay? You have proton pump inhibitors in your back pocket, right? So anyway, this is what happens, right? Pressure goes down because you lost half of it. You still got the diaphragm working, but you lost half of it. This cartoon. And basically, what you do is you come in and reflux. If you have acid and pepsin, those are the major ones that are called. If you remember, pepsin optimum pH for pepsin activity is acidic. So if you have acid and pepsin is working very nicely to destroy your tissue. And if you get rid of the acid, pepsin doesn't work anymore, okay? Not effective. And the proton pump inhibitor will stop this. But essentially what you're doing is once you injure, keeps going, more injure weaker muscles, etc. Then you get GERD. The problem with GERD, There's Barrett's esophagus, yeah, Barrett's esophagus, and the tendency for, I have another slide for developing carcinoma. And this is what reflux disease looks like. Gonna have hemorrhage even, it's kind of, they're always gonna show you something that's pretty extreme, right? But you'll be able to detect on endoscopy irritation for sure. These list some of the things that go on, including Barrett's esophagus. You can just read that, no big deal. Regurgitation. See that iatrogenic that I talked about, that. You made a decision based on your patient to treat his malnutrition or her malnutrition by doing a knowing you can stop acid secretion. And this is the best maneuver. It's called decision making. Right? And they do that. All right? They know. You just put the person. The major complication of myotomy is going to be GERD. Okay, regurgitation. I think all of us have had that a little bit. Well, babies have it. As an adult, you can regurgitate food that you've eaten or something. And you can even taste it. It tastes like the food you've just been eating. Okay, which is okay. That's the esophageal origin. Secondary peristalsis, you'll swallow it yourself if it comes up that high. But if it starts being acidic, or what do they call it, sour, bitter, that's acidic, now you know that's not coming from your esophagus. It's coming from your stomach. That's right. Okay, so that's an interesting thing about regurgitation. But that can happen commonly. It's not a problem. And you have secondary peristalsis, etc., that help move things back into the stomach. It's not associated with nausea or retching or any of these abdominal contractions or vomiting. I have to cover vomiting for you as well. Emesis is another name for it. But basically you have two orifices in the GI tract, your mouth and your anus, right? If you have an irritation or problem with material, toxic material in the upper part, generally it's going to be vomiting. If it manifests in the lower part, you're going to have diarrhea. Wherever's closer, you're going to get rid of it, right? So here in the stomach, you're going to have excessive irritation of some kind, and also in the duodenum you can have it. You can have vomiting from even the duodenum. And usually you can tell that the vomit will have a yellowish color in the bile, okay, if you get it from the duodenum. It's rare. Most of it will happen from the stomach. And you have, again, that's a nice thing to know, vomiting center, right? Goes up. These are afferents coming up. They're all sense material, toxic material. And then you're going to elicit a reflex. You're going to have efferents coming down. You're going to lower your lower esophageal sphincter pressure. And guess what? Everything's going to happen just the opposite, just like with swallowing. Don't forget, you still got that final common pathway you have to deal with. And so when you're vomiting, you're also going to contract your abdomen and diaphragm muscles, or Valsalva maneuver, if you know what that is. That's like breathing against the closed glottis. And you can have retching originally, which is just like that. Material will come all the way up into the esophagus. But if you don't overcome the pressure in the upper esophageal sphincter, no vomiting. Okay, and you just basically clear it with secondary peristalsis. With the actual vomiting, that it's called relaxes. It's to emphasize that the stomach does not contract, because a contraction would actually work against vomiting. What you're doing is everything just, you have your lower esophageal sphincter is going to relax, you have abdominal pressure going up, and squeezing the stomach, not contracting. Everything gets pushed up. The only thing stopping it is the upper esophageal sphincter. And that's retching, okay? Once that pressure is strong, I don't know if you've ever, most people have vomited before, but before vomiting, sometimes you feel like vomiting, but it doesn't happen. Well, that's what's going on. Your system wants to expel the vomiting, but can't overcome the pressure, all right? And you have secondary peristalsis, pushes everything back down. Eventually, if it's serious enough, you will overcome the upper esophageal pressure, and you'll expel it. And again, you're gonna have the very same thing, epiglottis closes over the trachea, and if you're not paying attention, something can come through your nose, usually you'll close off with the soft palate, your nose, exactly like what happens with swallowing. You protect those areas, and the vomitus is ejected from the mouth. And you also inhibit respiration, just like with swallowing. But everything is just, it's almost exactly the same, okay? Okay, from the duodenum, that's the only place that you have reprogrammed. Usually the myenteric plexus has an internal program, the circuitry is programmed, relaxation downstream, contraction upstream, so you always have this movement down toward the anus. That's the way the circuitry is programmed. But you can reverse that, and they call this anti-peristalsis. And that's when an irritation happens in the upper part of the duodenum. It's a long way down to the anus, a lot quicker to go up this way. And that's what happens with vomiting. That's excessive vomiting. Now, I think you know pretty much this. Motion sickness, it's chemoreceptive. It has nothing to do with irritation in the GI tract. It's centrally mediated. And if you've been on airplanes, right? And reach into that pocket in front of you, get a little bag there. It's not for you to keep your things in, it's if you decide to vomit. That's what the bag is there for, so you don't offend everybody around you. That's exactly what the bag is there for. Drugs, that complication of people, whether rock and roll stars, do too many drugs or something, you literally drown in your own vomitus because the respiration isn't even inhibited, okay? The nervous system is so depressed. Well, you're not gonna get pregnant, I don't think, but then you have emotional things, but this is the problem. Pulmonary aspiration is the major thing you gotta watch. The vomitus, same thing, it's got common spinal pathway you're dealing with. You have to protect it. And this is, I think Walcatano covers these kind of things. And I don't know much about this except it doesn't look good. It's excessive strain on the mucosa. The tear, it's basically a tear. That's named after these two people. Okay, that's all I had. You okay?
Yeah, no, thanks.
You guys just had an exam, right? This morning?
Yeah.
Good for you, Frank.